Hi, this is Brian Kim. I'm going to share with you part 2 of traumatic cataract. If you look at my previous video, this patient had a traumatic cataract, actually some facial lacerations as well. And then I performed cataract surgery, but this patient had also zonular dehiscence. I placed trypan blue and it bled into the vitreous space, and it was a challenging cataract removal. I had to place capsule retractors as well as a capsular retention ring and then a sutured capsular retention segment. But this patient also has traumatic mydriasis. So that case was rather long, and so rather than doing it all in one video, I decided to break it up. And this is the last part of this case. Again, the cataract surgery has been done. The capsule tension ring and capsular tension segment has been sutured into place, and the lens is very well centered. And now I have this traumatic mydriasis, which I will fix with the pupillary cerclage technique using the 4th row pupilloplasty. So I'm filling the eye with some more dispersive viscoelastic, and then I'm grabbing the edge of the pupil with the serrated IOL holders, and I'm using the serrated IOL holders to get a better grip of the pupillary tissue. And you can see it's rather stiff, but I'm going around very carefully, holding tension, pulling and holding tension to be able to constrict this pupil as much as I can manually first before I perform the cerclage. As you can see, I'm just pulling all the way around. And thankfully, this patient has a pretty robust iris tissue. It is a dark pupil, therefore nice and thick iris tissue. And I'm just going around circumferentially, grasping the tissue, getting a nice grip of it, and trying to minimize any damage to the iris tissue. You can see I'm not getting a whole lot of pigment liberation as I'm doing these maneuvers. And I'm just going around 360 degrees, just getting a nice healthy grip, making sure I don't rip the tissue, trying to loosen the tension on this traumatic mydriasis pupil. And I'm just going around, just grasping and grasping. And I do feel like there's no iris tissue loss in this situation. So now I have to perform the pupillary cerclage, and I'm going to do the 4th row pupilloplasty technique. So this is the needle in my right hand. I'm already inside the incision here, do my paracentesis incision. And what matters is the proximal paracentesis incision. I want to make sure when I externalize that needle that I don't capture any corneal fibers. And so as I pierce that first part of the iris tissue, I very carefully then pierce the proximal side. This will allow the pupil to come down. And then I'm using the cannula, a 27 gauge cannula, and I'm placing the needle, docking the needle into the cannula as I externalize it through the main incision here. Very carefully. And once it's pulled in, you want to grasp it with forceps so that the end of the needle doesn't flail wildly and scrape the cornea. As I pull it through, I grasp the distal part of the suture on the other side with the bond hook, and this creates a nice loop. And then the 4th row pupilloplasty is pretty simple. You're grasping the loop, making sure you get the orientation, make sure it's not twisted around, and you're going to basically pass the free end into the loop. So you can see here, I'm just going around, passing the free end through the loop for a total of 4 times. You can see going around, and this just simplifies it this way rather than just twirling it over your forceps. And you can do it both ways, but I feel like this just gives you a lot of control. Once you do the 4th rows, you pull on the free end on either side, and the sliding knot, the CIF-4 sliding knot, then slides into the eye and cinches the pupil down. So you can see nice cerclage of the pupil, and then using micro forceps to cut the ends of the suture. And that's really it. I'm going to do this multiple times, I believe 3 or 4 more times, and it's just rinse and repeat. Okay, rinse and repeat. Grasping the iris tissue again, trying to get some stretching of that tissue. And remember, you can do a baseball suture, but it's rather tedious and cumbersome, and honestly, this technique is so much more efficient by doing interrupted pinch cerclage. So using forceps to pierce that iris edge on the distal side and then on the proximal side, placing the needle through that cannula, do the paracentesis incision very carefully, guiding the needle out of the eye, and then very carefully grasping the tip of the needle, making sure the tail doesn't flail around and scratch the cornea. And you want to kind of direct it down. And so that's what you saw there. And this is the bond hook. Again, lassoing and grabbing the suture on the distal side, emanating from that distal incision. And now you pull out the loop. And once you have the loop, you're going to take the free end of that suture and loop it through that loop 4 times. And that's it. So I'm grasping the free end. I'm going around, looped it here. Again, using 2 forceps, going around, looping it, looping it again, looping it again, and then looping it. I think this is the last one. Okay? And then grasping both ends, pulling it from both sides, and you can see the knot sliding in, and then cinching the pupil down. So you can see a pretty nice closure. We're getting there little by little. And once you cinch it down, the knot on the iris tissue edge, it creates, again, this very nice and tight closure. You don't have to do multiple passes. You just do that single pass, 4th row pupilloplasty. It works very well, very stable. And you can see that it's going to be stable because at the end of the case, I'm going to do IA. And as you do IA, it does cause a lot of pressure inside the eye, and it can cause that pupil to expand when you do IA. But you can see that the pupil stays nice and round and small throughout that maneuver. Go ahead and pass the suture one more time through each end of the iris tissue, getting around 2 to 3 clock hours. And then placing the needle into the cannula again, very carefully sliding it in, as well as trying to carefully externalize the cannula. By doing it that way, you're making sure that no corneal fibers are going to be incarcerated while you're doing the 4th row pupilloplasty. And then I go ahead and use the bond hook to grasp and hook the distal suture, externalizing the loop. And then basically doing 4 throws around the loop with the free end of the suture. Pulling both ends, and then it causes the knot to slide in. And that is the 4th row pupilloplasty once again. This is rather redundant, but I just wanted to show this case in its entirety and seeing the repetition of the 4th row pupilloplasty to allow people to see exactly how you do it, and so that they can do it for their own cases as well. So I thought I'm done here. I go in with the ironing handpiece, removing all the viscoelastic. And I feel, again, really confident because the lens is in the bag. I'm removing the viscoelastic. You can see the pupil stays nice and tight. The suture does not unravel. So again, you didn't have to do multiple passes of the suture in this process. So again, just a single pass with 4 throws. And that cinches down and secures that pupillary cerclage configuration. So as I make my incisions, I'm feeling pretty good about myself. Again, this patient had traumatic cataract with zonular damage as well as a traumatic mydriasis. You can see I performed a bunch of maneuvers, and you can see that on my previous video, but this video was really focused on the 4th row pupilloplasty, placing strategic paracentesis incision, placing that 10-0 Prolene on the CIF-4 needle through those incisions, using micro forceps to pierce through the iris around 2 to 3 clock hours apart, and then hooking the distal suture with the bond hook, pulling out the loop, looping that free end on the same side through that loop 4 times, pulling the free ends on either side, and then the knot sliding in, and then cinching on the pupil, creating that cerclage. So again, you saw I did really nice closure of this pupil. Yeah, even though it's not perfectly round, If you did a running suture all the way around, that creates a perfectly round one. But it's really cumbersome, and it does create a lot of manipulation of the tissue. And honestly, what's more important, making it perfectly round where a patient really can't tell from the naked eye, or getting that pupil nice and round, but really over manipulating the tissue, causing a lot of pigment liberation, causing tissue loss in the process. And so I felt like this was the lesser of two evils. Yeah, it's not perfectly round, but at least I didn't over manipulate the iris tissue, and this patient did great. So I hope this was helpful to you, and I thank you for your attention.